So I'd like to talk a little bit more about the 5-year overall survival data that we have seen from CheckMate 9LA at this conference, and wanted to get your impressions on the 5-year data. What do you make of this? Does this, I guess, change your impressions of the particular regimen?
You know, we've now seen 5-year of CheckMate 189, 407. We are seeing 9LA here at ASCO, and we have longer term also for Poseidon.
Yeah.
I think that overall the way that I interpret the data is, number one, you know, you have some patients that really benefit from immunotherapy across all of these trials. Clearly PD-L1 as a marker for enriching for that magnitude of benefit. So the PD-L1 high people with PD-L1 high expression in their tumors, you know, clearly those are the people that are benefiting the most. We know that. I don't think that's any surprise as we see the 5-year data. What we saw with the updated analysis now of the CheckMate 9LA is the 5-year overall survival in all patients of 18%. And I think, you know, we were talking about how Keynote 189 and 407 for all comers, 18% is kind of what we saw. And then looking at the subsets of who is benefiting less across the trials of chemoimmunotherapy, we talked about how the PD-L1 subset seems to have, you know, a less benefit, but still benefiting compared to chemotherapy. And then when we look at CheckMate 9LA, I think it really is striking to see the PD-L1 negative subsets do seem to have that benefit from immunotherapy with the addition of the CTLA-4 inhibitor and the squamous population. So those are the two sort of subsets that come out sort of as people that historically we've seen, you know, inferior outcomes compared to the other subsets of PD-L1 middle, ground, and high. So I think the CheckMate 9LA data, the 5-year survival, it's really nice to see. I don't think there were any surprises, but it also tells me that we still need to focus on those subsets. We still need to focus on how do we get more benefit for people with PD-L1 negative tumors and also the squamous population.
Any other thoughts?
Well, I would agree. I mean, if you think about how we came to develop these trials, CheckMate 227 was actually the trailblazer, and we saw in Part 1B of CheckMate 227 a unexpected and pretty significant long-term positive outcome in the PD-L1 negative subset with an overall survival of about 30% at the 5-year mark. So that set a very high bar, and certainly not data that we were able to fully reproduce. This may be because of the negative impact of chemotherapy, or it's may just been a sort of a trial result that was a little variable, but it certainly laid the ground that we were able to reproduce in CheckMate 9LA and Poseidon, that in the PD-L1 negative disease we do see across the histology types, but preferentially in the underperforming squamous subtype, an increase in long-term survival. I think those are numbers that are quite reassuring. We don't have quite the full 5-year follow-up for Poseidon. For CheckMate 9LA, now very clear that we're seeing levels here that are higher than expected. Very difficult to analyze the trial without having a PD-1 arm intrinsically. So it would be nice for intrinsic comparison. But I think in historical comparisons, I think we don't see any benefit with PD-1 in the long-term setup in the PD-L1 negative population, and a very marginal benefit in the non-squamous population in in Keynote 407 and 189 respectively. So I think this is a very stronghold where we underutilize CTLA-4 inhibition. So I think this is proven in 3 trials, 2 agents, where this should be utilized. And then again, case by case, I think high-risk distribution, CTLA-4 and circulatory lymphocytes may be the reason why we're seeing better brain metastatic coverage for these patients. We really have an egalitarian effect between brain mets and no brain mets in CheckMate 9LA. It's very nice to see. And obviously the sensitization of squamous cell is going to be very, very useful. So I'm very happy that we have these regimens available. The NCCN guidelines support ipilimumab, nivolumab as a chemotherapy-free option for the PD-L1 zeros. And I think that's the signature utility for the drug. So I think we need to look at the toxicities, discuss it with the patient. But in a patient with a negative and unfavorable biomarker setup, it is really one of the immunosensitizing opportunities.
When I look at IO versus chemo type trials, one of the first things I look at in that OS curve is, do they split early on? And so for like 227, they do. You know, maybe Empower Lung 1, they don't. So, but that informs me as a practitioner that there's still a patient population, unfortunately, that needs chemo, right? And so we're not there yet. Maybe in the era of BiTEs and ADCs, we can cellular therapies for solid tumors that we can move past that. But I think we're still in that era where there are patients that unfortunately still need chemotherapy.
Yeah, and I think we have these caveats of looking at these subgroup analyses, doing these cross-trial comparisons, which we're really not supposed to be doing, but that's all we have to guide us.